This is a pre-recorded presentation, so the presenter will not be taking any questions. However, all questions asked during the live presentation, along with answers, are included at the end of this presentation. To learn more about our upcoming patient and family conferences in your area, please visit aamds.org/conferences. To view other recorded presentations or to register for other live online learning events, please visit aamds.org/learn. Welcome to our live webinar titled Fertility and Bone Marrow Transplant, What You Need to Know About Fertility Preservation. Thank you for joining us. My name is Angie Onofre, Director of Patient Education at AAMDSIF, and I'll be moderating the presentation today. As we get started, I would like to acknowledge the generous support of Be the Match and our patients, families, and caregivers in making this webinar possible. With that said, Be the Match is operated by the National Marrow Donor Program, a nonprofit organization that matches patients with donors for a blood or marrow transplant. We also educate healthcare professionals and conduct research so more lives can be saved. The Be the Match Patient Support Center is dedicated to supporting patients, caregivers, and family members before, during, and after a transplant. Be the Match offers confidential one-on-one support, financial guidance, and free educational resources, DVDs, booklets, and online tools, and more. We can help patients, caregivers, and families learn more about transplant as a treatment option, plan for a transplant, and learn what to expect after a transplant. Today's presenter is Nurse Christina Ferraro. Christina graduated from The Ohio State University in 2001 with a Bachelor's of Science in Nursing and went to earn her Master's of Science in Nursing at Kent State University in 2016. She has been working in the blood and marrow transplant program since starting at Cleveland Clinic in 2003. First as a staff nurse and then as a BMT nurse coordinator, and now as an outpatient BMT nurse practitioner. With that said, it is my pleasure to welcome Christina.
Hi, I hope everyone's having a good day. Today, we're going to talk about fertility and bone marrow transplant and what you need to know about fertility preservation. So we're going to start with our objectives. Today, we're going to understand why fertility preservation is important for patients living with aplastic anemia, myelodysplastic syndrome, and paroxysmal nocturnal hemoglobinuria. We're going to describe fertility preservation options for both men and women, and we will talk also about pediatric patients and the implications for those. We're going to identify resources that are out there for fertility preservation, and we're going to go through some questions that you may want to ask your physicians or your team about in order to preserve your fertility or to talk about what that means for you. So fertility is defined as the ability to conceive a child. For women, that means having eggs mature and release. This starts at puberty, which is typically around 10 or 14 years of age, and that's indicated by when your menses starts. And it ends at menopause, which is normally around 50 years, give or take, and it's defined as the cessation or the stopping of your menstrual cycle for at least 12 months. Women are born with all of the eggs that they will ever produce in their life. So if there's any damage to the tissue or the eggs, it is irreversible. For men, fertility is producing healthy sperm. Fertility starts at puberty for men around 12 to 16 years of age. Men, though, unlike women, will continually produce sperm for their entire life, which means that men can become parents throughout their lifespan. How can fertility be affected by cancer treatment? So chemotherapy, radiation, and surgery can all affect the fertility in different ways. It can decrease the number of sperm or egg that are available. It can lower the quality of sperm or eggs, decreasing the level of hormones that control reproduction, and it can scar the reproductive organs, which can prevent the conception or the normal development of a healthy pregnancy. Growth factors and immunosuppression, which is also used to treat aplastic anemia, MDS, and PNH, are actually unknown effects on fertility, though some medications can cause birth defects if someone was able to get pregnant. For example, mycophenolate is a medication that we recommend patients not get pregnant on, as it can cause birth defects. Examples of some treatments that people can see with their MDS, they can get azacitidine and decitabine Aplastic anemias, this is when you get immunosuppression called ATG or cyclosporin, tacrolimus, Campath, prednisone. PNH is incluzumab. Growth factors that can be used in addition to other treatments, Epogen or Procrit and Neupogen. These are stimulating the red blood cell and the white blood cell production. High-dose chemotherapy followed by a blood or marrow transplant or BMT. So I'll shorten it for the rest of this talk, so that way you know what it is. Each treatment can have very different impact on fertility. Some of the treatments are very low risk that affect the ability to get pregnant, but BMT is actually very high risk to affect fertility. When is the right time to talk about fertility? Well, the American Society of Clinical Oncology recommends having the fertility discussion at the time of diagnosis. Really, the earlier the better. So more information can be gleaned from each individual patient. Options are more, there are more options for patients if talking about this earlier rather than later, and it gives you time to sort of make that informed discussion. It also helps with referrals, earlier referrals to reproductive specialists or endocrine specialists. The medical team is not necessarily very good at discussing fertility with patients, so it's important that you don't hesitate to bring it up with your physician or your team. These are things that aren't necessarily on the top of their mind, and we need to get better about it. So as your advocate, it's important that you and your family ask questions. There are some challenges to applying this particular guideline to BMT patients because sometimes there is no time and we need to bring that patient to transplant sooner rather than later. So that's why if you can have the conversation earlier, it just makes everyone have the ability to offer more options. So this is a schematic of the guideline, and it's really, the first one is assessing that risk for infertility and communicating with patients and their families, and really looking at the chemotherapy or the treatment and deciding, are we looking at a high risk or a low risk? So those patients who may be starting out with just monitoring phase, they may be at lower risk, but those who may start treatment may be thinking more moderate risk, and those who need to come to transplant would be at high risk. And really referring to the specialist up front to have that conversation to discuss whether or not fertility preservation techniques need to occur. There are we're going to talk more about the kinds of preservation that are available in a little bit. So an introduction to BMT. So it is a treatment used to treat life-threatening blood, immune, or genetic disorders. Basically, we give very large doses of chemotherapy and replace a dysfunctional immune system with a new one. Donor cells are used. These are collected either from the peripheral blood by using apheresis or by a bone marrow of someone else, and that's done in the operating room where they go into the hip bones and collect the marrow directly from that source. Donor cells can be collected from a relative, from a stranger or an unrelated donor, volunteer, or from the umbilical cord of a newborn baby. Those are collected at the time of birth and frozen for later use. This is a pictorial diagram of what we do for transplant. The recipient is given high doses of chemotherapy with or without radiation. The healthy donor cells are collected, and then the recipient is given those healthy cells through an IV in the arm or in a port in the chest. And these are given like a blood transfusion. So really, the chemotherapy and the radiation is to suppress or completely get rid of the marrow of the recipient. So all those diseased cells or those abnormal cells that aren't functioning well, we want to get rid of those. So you give as much chemotherapy that's safe, and then you take those donor cells and infuse them into a patient like a blood transfusion. At the time, those donor cells move into the marrow space and start to grow, and a new immune system is produced by those healthy cells. And you start to get normal blood work, blood counts, those kinds of things. The high-dose chemotherapy targets fast-growing cells, so it's not smart. So it'll go for healthy stuff and the bad stuff. So it'll go for the bone marrow cells, but it also will affect hair and skin and nails, the lining of the gastrointestinal tract, which is why patients get nausea and vomiting. And then it also affects the gonads. And the gonads are your testicles and your ovaries, and those are where the eggs are produced and mature, and your testes are where the sperm's produced. And so when you have chemotherapy and radiation affecting those, you can stop menstrual cycles, you can affect the hormone levels, you can push a patient into early menopause and stop sperm production. Immunosuppression medication, which we use after transplant, we put patients on for prevention of graft versus host disease. Graft versus host disease is when the new immune cells, or those new bone marrow cells, recognize the new body as being foreign and try to attack it. And this can look like rashes or nausea, vomiting, diarrhea. It can affect any system. So it's a lot of monitoring, and we use those immunosuppressive medications to try and prevent that as much as we can. Now, those medications, as we've learned before, can affect fertility or should not be, patients should not be on them if they are trying to get pregnant. So there are a lot of other factors involved, not just the high-dose chemotherapy, not just the radiation that we give, but age. So patients who are over the age of 30 have a higher incidence of having infertility after transplant. If you're female, and that's we talked about, you have a limited number of eggs at the time you're born, and at the end of your fertility lifespan, when you're getting closer to menopause, you have fewer and fewer eggs. We say diagnosis, but really it's not necessarily that the aplastic anemia or the leukemia have a higher incidence of infertility. What it is really the treatment that we give ahead of time. So that's sort of the same thing as the next one, which is the type of treatment, the number of cycles of specific kinds of chemotherapy or radiation. Aplastic anemia patients may be getting blood transfusions, growth hormones that may or may not affect fertility, but leukemia patients may be getting much more intensive chemotherapy that can. Time available prior to starting your treatment for transplant can be a factor. If we have some time, you have 3 or 4 weeks to get ready for your transplant, you may have time to protect your fertility by doing some preventative things. If we have to, due to disease status, we have to go to transplant quickly, we may not have time to preserve fertility ahead of time. Partner availability, and we'll talk about what this means, but if you are not with a partner at the time of transplant, some of the options available wouldn't be a good choice because you would need to have 2 people. Types of transplants, there are multiple versions of chemotherapy that we use, and reduced intensity transplants are they're moderate doses of chemotherapy to make room for the new immune system, but don't completely get rid of that recipient's marrow cells. And so they don't have as much of an intensity with the rest of the normal cells that a fully ablative transplant or a myeloablative, which would completely wipe out the immune system. So the dose matters if you get a reduced dose versus if you get a very, very high dose. That can affect the fertility. Certain chemotherapies and definitely total body radiation as part of the transplant can affect fertility more than others. Busulfan and melphalan, or busulfan and total body radiation have a higher incidence, whereas maybe melphalan and fludarabine are not as much of an impact to fertility. So when you look at the spectrum of when you have your diagnosis and then through transplant and then post-transplant, you can see that there are many factors in fertility. So before the transplant, if you had any fertility issues to begin with, so if somebody had endometriosis or early menopause or other factors that would affect fertility patients with or without chemotherapy, that doesn't go away, and we still have to use that as part of the decision-making process. When you're diagnosed, then you get either treated with chemotherapy, radiation, monitoring, immunosuppression. Those things can affect even before you get to transplant. And then once we do transplant, chemotherapy and radiation. And then afterwards, if you get graft versus host disease and other side effects of the treatment, infections, any medications you may be on, those can also affect it. So this is a spectrum over a long period of time that can affect the ultimate outcome. So recovery of fertility after transplant. So when we look at men, about 70% will have a decreased sperm count after transplant. So that's to be expected. Remember, fast-growing cells are affected by the chemotherapy and the radiation. And about 90% of those people will recover their spermogenesis, which is production of the sperms, after receiving cyclophosphamide alone. But when you look at patients who've received cyclophosphamide and busulfan or Thiotepa, which are medications also used in transplant, only about 50% of those 70 will recover their spermogenesis. And if you look at patients who have received total body irradiation, it's about 17% of those 70 people will recover their sperm count. Now, that can be dose dependent. So if you have a reduced intensity transplant with lower doses of radiation, that can be different than if you get higher doses. And really, it's hard to, all the data out there, this takes a long time. So if you look at some of the earlier information, 2 to 5 years after transplant, your number of percentage of patients that recover their ability to produce sperm could be lower than if you look at 10 years down the road. The longer you have after transplant, the more of that fertility comes back. And that's important to remember. Females, though, on the other hand, remember, this is also different with females versus men because females really are only, you're born with what you got, you don't get any more. And 90% of females will lose ovarian function after transplant. And ovarian function is determined by having a menstrual cycle and hormone levels, blood work that they check. 92% of those 90% of patients will regain their ovarian function, which means they'll get their periods back, their hormones will return to normal if you are getting cyclophosphamide alone. But if you do cyclophosphamide and total body irradiation, only 24% of those 90% of patients will get their ovarian function back. Now, if you get your period and you have hormone levels, it does not necessarily mean that you are fertile. And that's important to remember moving forward, that once again, it's not necessarily confirmed that you'll be able to get pregnant, but it's a possibility. And so that's important down the road. For children and adolescents, it's a little bit difficult with those patients, those kids who are prepubescent, so haven't started periods or producing sperm, versus those kids who are after puberty and up to age 18. So younger kids and children and adolescents tend to they lose their fertility about 50 to 70% of time in men and 55 to 85% in females. But they do have an increased regaining of that fertility after transplant. So the younger you are, the more likely you are to get your fertility back. So conception rates after transplant. So how do we know how many people can get pregnant? Well, it's really hard to get that information correct. So the data collection is not very clean. It's hard because of the reporting system. It's how often do patients tell their transplant team that they were able to get pregnant, and how many people don't see their transplant team anymore. So that's really hard to keep track of. And then with the new ways we have of fertility preservation, there's not a long enough follow-up time to really get a good grasp of how we're doing. And do we know how many patients have been trying and have not been successful? That's not something that we routinely keep track of either. So we recommend also that transplant patients not try and get pregnant for 2 years. And the reason that is because the risk of complications and medications are very high within those first 2 years. And we don't want to affect your recovery. We don't want to harm yourself by early pregnancy and stressing out the body and worrying about multiple things going on if possible. And then the risk of relapse really decreases after 2 years after transplant. So that even puts you at a better place in the transplant process to really look at that. And remember that as you get further and further out, fertility may increase, and that's important so that you know that after 2 years, you may not be fertile then, but it could be, 5 years down the road. It is important, though, that we really talk about contraception post-transplant. So remember that just because if fertility rates are low after transplant doesn't mean it's not possible. I do have patients. I have one patient, 9 months, who got his wife pregnant, not by our recommendations, but it happens. And so it's really important that contraceptives are used within those first 2 years. So pregnancy. If I get pregnant after transplant, what should I expect? So prior to getting pregnant, it's very important to discuss all the risks and benefits, not only with your transplant provider, but a reproductive specialist. So either the person who helped with your fertility before the transplant or an OBGYN after, because you really want to make sure that you are being as safe as you can once you get pregnant. Your current medications can affect your pregnancy and the fetus, and so it's important that we adjust medications if needed. If you want to get pregnant but you're on mycophenolate, we would need to change that medication for you and figure out a way to be able to do both for you. And pregnant women who've had a transplant should be monitored more closely. So making sure that you have a high-risk OB to keep track of any pregnancy-related complications, because there are some increased chance of having a cesarean section, maybe having an early delivery, or even low birth weight. So it's really important that patients really pay very close attention, and pregnant women are monitored very closely. And these are women who've had transplant. Now, if you've a man and you got your wife pregnant or your significant other pregnant, there's no higher risk for that woman who's pregnant. So it's really the pregnant woman who has had a transplant that needs to be monitored more closely. How healthy will my child be? There is no data showing that a child born to a BMT patient are at higher risk of fetal malformations, which means, no risk for more birth defects in the general population, and there's no increased risk of developmental delays. And most cancers or most diseases that we transplant for typically are not known to be inherited, but that's another reason why it's important to have the conversation with your team before getting pregnant so that you are aware if your disease is one that can be inherited or not. So what can be done about fertility in transplant patients? There are options. We talked earlier in the webinar about earlier the better, and it is important that we talk about it as soon as we can, preferably done before starting your treatment, and definitely better before starting your transplant process. So having that part of the conversation very early would be good. So either a consult if you're transplanting and you're going to go to your consult appointment, ask it there. If you have already been through that process, you can call and talk to them. The options, each one has pros and cons, and it's important to understand the differences and the risks involved. And the type of disease does make a difference. So certain diseases would be more challenging than others, a non-malignant disease versus a malignant disease. So what are the options? They're different for females and for males. So there's ovarian suppression, which is giving you basically gonadotropin-releasing hormone analog treatments, which are used to shut down the ovaries. And that is, for an example, Lupron. It temporarily stops those ovaries from producing those eggs to release in order to decrease the effect of those chemotherapies on the rapidly growing cells. Now, this is not this isn't perfectly figured out yet. So we use it and we've used it here at our facility, but it's not exactly the frontline proven 100% going to protect your fertility. So it's an option for those patients who maybe need to come to transplant faster, and we just need something to try. Ovarian shielding, which is shields are placed over the ovaries during the radiation treatment. This is not necessarily optional for everybody, so it really depends on the disease. If you have leukemia, then these are not necessarily things you would want to use because you could have disease hiding in those spots. So we don't shield for those type of diseases, but others might be possible. Ovarian transposition is just when the ovaries are surgically moved higher into the abdomen, away from an area that will be radiated. Also depends on the disease and not necessarily something that's used for all patients. Removing the eggs and ovary tissues for future use. So one of these options is in vitro fertilization. What they do is they harvest the eggs prior to your treatment, to starting treatment. You fertilize them with sperm in the lab and freeze the embryo. Eggs can be of the patient if harvesting is done prior to treatment, or donor eggs can be used if the patient doesn't have enough eggs, or if this is done after treatment and the likelihood of getting eggs is very low. Those women would need to take hormones prior to harvesting the egg in order to get the ovaries to release a mature egg. The egg and sperm are combined, and then the embryos are frozen or can be implanted at that time, depending on when this is occurring, and they can be frozen for future use. So the hormone treatments are what we really use to stimulate, and those are shots. Typically, they're done for a few days ahead of time to really get those ovaries working. The egg retrieval is a surgical procedure where they go in and they remove those eggs. They use sperm in the lab to inseminate the egg, and then they watch those two cells grow together into an embryo for a certain amount of time, and they check the viability, and then they freeze them or they transfer them into the uterus. Egg freezing on its own, basically it's the first two sections of in vitro fertilization. They stimulate, and then they egg retrieval, and then they freeze those eggs before they've been fertilized and can bring them out later to use. Ovarian tissue freezing is a little different, where they take an actual section of the ovary and freeze it in multiple sections for future use, and they can reimplant it later. Now, this is one of those, still not sure if it works yet, but this is an option for prepubescent girls who haven't gone through their menses as a potential option. Another way is if you really don't have time to do in vitro fertilization or egg freezing, or the cryopreservation of the egg, then you can use this for patients who need to come faster. This can be done laparoscopically, and it can be done rather quickly without hormone stimulation, which can delay things. For men, it's a little bit easier. They can sperm bank, so they ejaculate into a cup and analyze and frozen and stored for later. Testicular Perm sperm extraction really is for men who are post-puberty, and the testicles tissue is collected for those stem cells, and then they're frozen and can be used later. For radiation shielding is also something that may or may not be appropriate depending on the disease, because we don't want the disease to hide if we're trying to kill it with radiation. But if you can protect the testicles during radiation, you can hopefully preserve some of that fertility. Testicular tissue freezing is what we typically think of for prepubescent boys, and that's also similar to the ovarian tissue freezing, where they take an actual section of the testicle tissue and freeze it for later. Also not proven at this time to be effective, but it's an option, and more time will tell if these are effective treatments. So some of these are relatively new, and it's why they're kind of experimental. So this is one of the recommended strategies for preserving fertility in children and young adults. And it's looking at the male side and the female side. So if you're male and you're prepubertal, which means prepubescent, the testy biopsy, which is that testicular tissue is cryopreserved and for later use. If you've gone through puberty or you're in the middle of puberty and you're able to get a semen sample, then that's what you'll do, sperm cryopreservation. If you are pubertal, post-pubertal, but you can't get a semen sample, then you would do a potential biopsy and gamete extraction, which would be still a little bit more experimental in order to cryopreserve that testicular tissue. If you're female and you're prepubertal, really your only option is that ovarian tissue. You save it for later. If you're postpubertal, then you're going to stimulate the ovary and get those cells out and either create an embryo and freeze that or freeze the ovary, the egg alone. Now, these are to get pregnant. Now, are there other options to having children? Yes, there's surrogacy. That's when an embryo is carried, or surrogacy is when you use a donor egg in a donor host for your child, and somebody donates sperm, or it's from your spouse or significant other. And then there's a gestational carrier, which really is they are carrying your embryo. And then donor embryos, those people who have had their embryos frozen but then never use them, you can get those, or adoption. So timing your fertility, men are a little bit easier. So they can sperm bank every 24 hours, and it can happen very quickly. Women, on the other hand, to collect eggs and IVF can take 2 to 4 weeks. So that means there may be a lot of time needed in order for this to happen. Experimental treatments like taking out the ovarian tissue or the testicular tissue can be more quickly, but early referral is still going to be very essential for all of this. And it's not proven treatment. So the cost of fertility, everyone wants to know how much it costs. So insurance companies may or may not cover this. This is something that you would need to call your insurance, check and see if you have any coverage, especially if you're going through chemotherapy or radiation. There may be options that are not available to you otherwise. Sperm banking is about $500 to $700 one-time fee, and that's to process the sample and then and freeze it. And then there's a yearly storage fee, which is about $300 to $1,000 per year, depending on where you are, obviously. Egg preservation, because of the hormones and the medications that you need, takes about $10,000, and then the $300 to $600 per year storage fee. IVF can cost anywhere from $13,000 to $14,000 at a time. Say down the road you want to use a donor egg. Those donor eggs can cost $24,000 to $25,000, and a donor sperm costs about $500 per vial. And then once again, that storage fee is anywhere from $300 to $1,000 per year. Say you have frozen embryos, they're waiting for you. It's time to take them out and transfer them either from a donor or from yourself. It's about $2,500 to do. And a gestational carrier or a surrogate can cost about $80,000 to $100,000 through an agency. So are there any options out there for financial assistance? So Fertile Hope is an organization that recently joined with Livestrong, and they do have an assistance program for fertility for cancer patients. So not everybody is eligible. The oncologist would determine that what we want to do for treating that particular cancer is high risk for infertility. And then an oncologist and a reproductive endocrinologist, which is those reproductive specialists, would have to determine that the treatment and the medications are medically appropriate and that there's no reason not to do fertility treatment. There's also specific centers that they work with that you would have to go through in order to get the help, financial help. And I did list the website so that you can go on it and see what's available for you and if there's any assistance that they can do. Resolve is the National Infertility Association. They do have some options for you to look, and pharmaceutical companies can help sometimes with the cost of hormones, because those are really where women have a lot of the finance, the cost of it is really from those hormones. And then check with the fertility clinic for payment plans and discounts. There are some compassionate care programs that allow for chemo patients or transplant patients. I know here we do have one that definitely gives a significant discount for our cancer patients. Other options or other places to look for other options would be the American Cancer Society. Here's some other resources that can talk to you about infertility. I put ours up there, but there's also Be the Match, which has got a lot of information about not just fertility, but post-transplant, long-term survivorship. The National Bone Marrow Transplant link has a lot of good support groups and a lot of good information, along with BMT InfoNet and Livestrong. So these are all really great places. The first 3 or 4 are really about BMT specific, and Livestrong will talk about cancer in general. So what kind of questions do I need to ask? So there's probably way more questions than I can ever put on a slide, but these are some of the ones that you should always think of at the top was, how will my treatment affect my fertility? Because it can be varying between each person, what your fertility may be ahead of time, remember what it would be after, how much time do I have before I need to start my treatment, what would be the risk of waiting, what would be not the risk, what should I do in time-wise, is this something that I can have time to do, or is this not something that I am able to do? And how do I know if I'm going to be fertile after treatment? That's a big question that a lot of people don't think about necessarily in the acute part of your treatment, but it's important to know. And what's the difference between early menopause and infertility? So remember that early menopause, that stopping of the menses for 12 months versus infertility, which is inability to conceive a child. So those are differences. What are my options to preserve my fertility? Do I have time for in vitro fertilization? Do I have time for egg harvesting, or should I go straight to ovarian tissue freezing? There's different options, and you need to know where you fit in there. And what are my options if I didn't preserve fertility before treatment? So if I didn't go through in vitro, if I didn't have time, if it wasn't brought up, if I forgot about it, if I don't have sperm in the freezer, what do I do? What can I do, and how do I go from there? And is my cancer inheritable? Can I pass it to my children? How long should I wait after my treatment to try and have a child? Some of these questions we talked about, but it's always good to talk to your team specifically about you. And can someone refer me to a locally who can help me with fertility? So that would be a fertility specialist and a reproductive endocrinologist. These are all people that need to be part of the conversation because they really understand how to go about preserving that fertility or talk to you about what your fertility would be afterwards. Thank you for listening. I hope I answered some questions, and I look forward to answering more.
A few questions that have come in.
Okay.
We have our first question from Lee. Lee's question states, does taking hormones to harvest eggs affect the success of a transplant?
They have not determined that at all. So no, as far as I am aware, taking hormones ahead of time to harvest eggs does not affect the transplant. These hormones are normally the hormones that you already have in you, and it's just a higher dose of them to stimulate those ovaries to produce more eggs and get them out sooner than they normally would, and potentially produce more eggs than they normally would on a routine monthly basis. And we've had patients who have done egg harvesting ahead of time and have had no issues after transplant because of that. Those are very quick-acting medications, and they're out of your system relatively quickly. So,
all right, thank you. And we just have 2 more questions left. If anyone that's currently still listening to the webinar, if you have any questions, please submit them, as we just have a few more. Our next question comes from Ellen. Ellen would like to know, is ovarian shielding or ovarian physician an option in bone marrow transplants with total body irradiation?
Not for our patients with total body irradiation, because you don't want to hide any disease that may be there, and you do want to make sure that you're treating the pelvis. So at this time, it is not it's experimental for chemo patients in general, but definitely for BMT patients, we would not recommend it.
All right, thank you. Our next question comes from Fred, and Fred would like to know, how long after transplant is it safe for women to become pregnant? Is there a time period for men to father a child?
We really do recommend 2 years for women to get pregnant after transplant. And we actually recommend for men not to get their significant other pregnant within that first 2 years. There's a lot of healing after transplant, and it's important that the focus is on that patient in order to get better. And then remember that the risk of relapse decreases significantly after that 2 years. And so that initial acute phase is over, and you can start looking into the future. Now, there is no, unless there's specific medication that patients are on that would affect the fetus, there's no harm necessarily for a male patient to get their significant other pregnant. They should still, if they accidentally do it, should talk to their transplant physician, and that female should get checked by their OB and evaluated on medications that they may be taking and what the risk would be for that fetus. Women who get pregnant earlier than 2 years, there isn't any information stating that they have a risk to the fetus, but there's a lot of immune changes, and when you're pregnant, your immune system is affected in a different way, and it can affect patients. And in that acute phase of transplant, when in that first 2 years, there's a lot going on. So the less you interact with that, the better, from a lot of different standpoints. So you still could be dealing with infection and graft versus host disease and all these other things, and a transplant or a pregnancy may affect that in unknown ways. You know, this isn't something that we don't recommend you get pregnant within those first 2 years after transplant for those very reasons. There's a lot of unknowns in there for safety reasons.
All right, thank you. Our next question comes from Lucy. Lucy says her sister is getting ready to have a second transplant. She would like to know, does this increase her risk of infertility?
Yeah, so it's a cumulative effect. So every time you get treatment, every time you get radiation, it will affect those healthy cells. So it will affect the ovaries, and it will affect the ovarian, the egg production. It affects the hormones. And each time it'll affect it more. So does that mean 100% she'll never be able to get pregnant? No, but is the risk, is the option, is the ability to get pregnant, it's very, very low compared to what it would have been the first time around.
All right, thank you. Our next question comes from Lee. Lee would like to know, are there any tests a bone marrow transplant patient should undergo to be sure they are ready for pregnancy? For example, having a blood test.
So a blood test for hormones, maybe. So there's lots of blood tests we do for transplant patients. Really, if you want to get pregnant and you're ready, the important thing is to know are you able to get pregnant? And that would be where a fertility specialist or a reproductive specialist would come in handy. We could do hormone levels, FSH and LH, which show whether or not the ovarians are producing hormones. And then also if you're having menstrual cycles. If you're not having menstrual cycles, the likelihood of ovarian function is very, very low. Ovarian function, once those hormones kick in, are you producing eggs? That's a little different. And that may be difficult to determine. Even if you do have normal hormones and you have menses, you're having a menstrual cycle once a month, it doesn't necessarily mean that those ovaries are producing eggs. So that's where those specialists will come in, and they would be able to do internal ultrasounds and all that stuff to determine if you are producing eggs and they're being released.
All right, thank you. And I believe those are all the questions that we got in. Once again, thank you, Christina, for your wonderful presentation and for your time. I would also just like to add that if you would like to rewatch this webinar at a later time, please be on the lookout for an email that will provide you with an archive link within 4 to 7 business days. On behalf of the Aplastic Anemia and MDS International Foundation, I would like to thank each and every one of you for joining us today and making us your resource of choice for information on bone marrow failure diseases. If we were not able to answer your question today, please send it to us via email at help, that's HELP, at AAMDS.org so that our patient educator can respond, or visit our online academy at AAMDS.org/learn for interviews with experts and other programs that may address your question. As a reminder, as soon as I'm done speaking, a post-event survey will appear requesting your feedback. We appreciate your time to complete this survey. Again, thank you for joining us, and remember, learning is hope. This concludes today's program.